Yeah. Okay, so if we could have our examining physicians to come up towards the front, and what we might do now is just recap in stages each of the patients. We'll probably spend the most time with the first patient on whom we did the more in-depth examination, and on the second and third patients touch on especially the salient features. So you remember our first patient, a 25-year-old Kuwaiti volleyball player with long-standing groin pain from 2009 until 2012. The groin pain was interrupting but not stopping him from playing volleyball. However, from April until now, he's been unable to play volleyball. The management so far has been some physiotherapy, which appeared to be some exercises in the water and perhaps some modalities that haven't met with much success. He's had bouts of 3 to 4 weeks of physiotherapy and not terribly much else in the way of intervention, it would seem. His pain is principally described as being perhaps proximal left adductor longus region, which he describes as feeling immediately from the commencement of games or training, that he feels initially as a stretching sensation and doesn't warm up. So at the end of the subjective examination, the history that you've taken, I would guess we'd be thinking particularly towards adductor longus or adductor region. What were some other thoughts that might have been guiding your subsequent physical examination, Zarko?
It seems that mainly his problem started from the left adductor longus, but considering the chronicity of the problem, he also developed left inguinal, some slight left inguinal problems on the conjoint tendon. You could see on the lumbar spine quadrant test, when I twisted him, he felt pain on stretching in the inguinal region, not only on the adductor.
Sure.
And also there is an involvement of the left iliopsoas, because as a big hip flexor that is taking over the role because of the pain of adductor longus. And now we had, it's been for a couple of months, if not years, we have the overuse of the iliopsoas muscle as well. So my point is, if you do physiotherapy, you need to address all these things, otherwise you wouldn't be successful.
Okay, so we've jumped ahead into the objective examination now, and as you mentioned, on a quadrant test, so typically we'd be thinking about extension compression of the contralateral lumbar spine, but in this case the finding was stretching of the anterolateral quarter, let's say, and that was reproductive of pain. And thinking back to what Adam showed us yesterday about the combined ranges of motion, that's clearly something that's going to be front and centre in our minds. The other things that we found on examination, it appeared that otherwise the lumbar spine active movements were unremarkable. Extension and left rotation reproduced left-sided groin pain. Then on examination, you went to supine and palpated the abdominal wall, inspection of the abdominal wall, from the pubic symphysis out to rectus abdominis conjoint tendon, and particularly he reported some pain over the inguinal ligament. Now at this stage, he's given us a history of adductor related and pain that he's pointing towards at the adductor longus origin, and the first finding that you found is pain in the inguinal ligament. How do you reconcile those two things? How do we say, can we, even at this stage, given it's been over 3 years history, this was primary, this was secondary, or does that not matter at this stage?
We can take a wild guess that it is the primary problem was left adductor, because it is slightly more painful than the other structures. But pectineal muscle is also an adduction muscle, and it's right below the inguinal ligament. So at one point probably takes over and also gets an overuse injury. So I really don't believe that you can stretch the inguinal ligament itself in a position. It doesn't contract, but the muscular structures around can contract and can be painful. And also the fascia that is in continuity from the abdominal wall towards the adductors in that region, going over the pubic tubercle, that can be a painful source.
Okay. I guess just before we go on, we've kind of skated over a little bit the subjective examination, the history. Was there anything else that anyone wanted to raise? And mindful of time, I'd ask you to be brief and focused with this. Anything else from the subjective examination that you think really would have been helpful or positive to add in for this particular case? From anyone? For the panel first.
Sorry. About this patient was that all the symptoms in the physical examination pointed to the adductor longus, But on Zarko's physical examination, the iliopsoas muscle came into play. And that's something that we seldom see or pay much attention to. So it was very, very revealing to see that amount of tenderness from the iliopsoas. The asymptomatic conjoint tendon split was totally unexpected. It didn't show up in my physical examination. It's asymptomatic, and one would hope that would get better with physiotherapy.
Anything else from the history? First of all, just perhaps focusing on that, not so much towards the physical exam. Nothing else anyone thinks needed to be added? Okay, fine. So then moving on to the exam, which we've jumped a little bit in towards, Zarko then went on palpating the psoas, starting on the right side, proximal to the inguinal ligament and distal. Resisted flexion, internal rotation of the hip was painless. Hip flexion, adduction, internal and external rotation was painless. There was a comment about perhaps some reduced range of motion, which again I'm thinking back to Adam's talk yesterday. Resisted flexion in inner range was painless, but Zarko noted an early movement of the pelvis and perhaps an inability to stabilise around that area. Squeeze, straight legs was painful, not at adductor longus. 45 degrees was painful, and at 90 degrees of hip flexion there was only slight pain. So it appeared worst straight, a little bit less 45, not as much up at 90. Passive abduction was painless on the right side, and resisted adduction was painless. Jumping over now to the left side, straight leg raise with pain on palpation was strong, and I've put 2 asterisks here next to adductor longus, slight pain to palpate. Figure 4 position, or Sartor Taylor sitting position, had some pain. Flexion overpressure gave from pain, which we're interpreting not so much as hip joint but as direct femoral palpation of the psoas muscle. Flexion external rotation was painless, but flexion internal rotation was painful, which I guess we're interpreting the same way. Hip flexion was painful but strong, you thought. So at the end of that examination, while perhaps we started the subjective thinking we were more along the lines of adductor longus primary, we've now got some pretty strong signs to think that there's a psoas involvement. And what do we think about, he did have some palpation pain at the inguinal ligament. How are we going to factor that into?
I would say that it is a secondary involvement.
Right. So at the end of the physical examination, we were thinking the 2 primary entities here were psoas and adductor longus. There was some tenderness on the left inguinal ring, not on the right. Pubic tubercle and inguinal ligament. You thought perhaps some tenderness at the pectineal line. We then were a bit rushed for time and found out that there'd been 3 PRP injections, which maybe gave a couple of months of help in total, an MR and an ultrasound, but we didn't get to the bottom of that. John added adductor tendon squeeze, and then we went through an ultrasound exam where I had to stop writing and start helping. So at the end of the physical examination, are we comfortable both here and also in the room that we could say that principally we're thinking about the primary entities are psoas, adductor longus, and there's perhaps of less importance some stuff at the, let's say, conjoint tendon, lower abdominal wall?
I think the lower abdominal wall stuff is referred pain.
Right. So how do we reconcile, if it's referred pain, the direct tenderness to palpate?
I didn't elicit any direct tenderness to palpation.
Okay. Anything else to add from the floor, Dr. Hamilton?
I was just intrigued because of the Zoa stuff. I thought someone would hang him off the end of the bed and do quite an aggressive modified Thomas to really tweak that and see how it goes. And the other thing is, you know, I'd just with my background, I'd be more interested in pursuing the extension-related low back pain as well. So I would have spent a bit more time looking to see whether that was etiological in some of his pain.
But yeah, that might not have been terribly clear that when the quadrant was done, the guy said the pain's here. So he wasn't talking about the pain here.
Okay, yeah, no, I
changed it
understand
at
that.
all?
Yeah.
So we were interpreting that as a stretch-related.
Yeah, no, that's fair. I'd tell that.
I agree completely, and that's you could say basic examination. But when you examine the groin, it's such a extensive examination. If you really want to address all points, and at this point we were a bit squeezed with time. But I agree completely. Fair point.
Okay, so now, were there other points to raise? I'm sorry if I'm rushing a little bit. I just really want to keep the day on time as best we can. So we've now got to the stage where we have this fellow who's had close to 3 years of pain, and in the last 8 months it's kept him out of his sport, more or less. He's on and off had some conservative management. What are we now going to tell him? What are we going to do differently? So are we going to stay with some form of conservative management? Will there be some intervention? What's our thoughts for our next step?
Well, the interesting point is he is an athlete from Kuwait, so we have no overview of the physiotherapy that has been done there. So if I could, my wish would be to keep him here and do a physiotherapy with you guys, and then we can really see some resolution, and then we can make sure if it's adductor longus or it's more inguinal at the end, that you, at the end of the line, maybe you could think of surgery. But if failed real physiotherapy with addressing all aspects that we found out with the iliopsoas treatment, with adductor exercise treatment for 8 to 12 weeks under supervision with real exercise, and then you'll have some idea.
So he said his pain at worst was 9 out of 10, and we're thinking 8 to 12 weeks to see a change. How much would we expect to say, yes, we're on the right track? So if in 8 to 12 weeks he says my pain is now 8 out of 10, I think all of us would say, look, we're not helping here. But do we think we're going to be completely fixed him by then? Is he down to 4 out of 10? What would constitute saying, no, we need to do something else?
Well, I agree with the point you made, and I also think that exercise therapy will be the way to go. I agree with Dr. Garvey that there was no signs of incipient hernia or anything that we wanted to jump for surgically. John also didn't find the bulging with the ultrasound. So I don't see any surgery out there, not even if we have problems in the long run. I would say intensive, well designed and well controlled exercise treatment for both the adductor problems and the psoas problems, and of course general pelvic stability exercises, coordination, proprioception, a little bit core as well, but the core would be part of the whole exercise treatment as such. And then, yes, if we after 3 months still didn't have any progress, we would be in trouble, and I'm afraid that the patient would also be in trouble. But I think that as we go along with this program, we will see progress. That's the experience, and that's also what we have from some of the studies. One thing that could be suggested was, especially if the psoas is giving problems, if it's very painful, if it's too hard to do exercises with the psoas, I have good experience from giving ultrasound-guided cortisone injection around the tendon. It's easy to do, and you can make sure you're not in the tendon, not making injuries as such. And then you can, with it, maybe 1, 2, up to 3 injections during 4 to 8 weeks, you can alleviate some of the pain. You can even see that maybe the thickened iliopsoas tendon will be reduced a little bit, and things will calm down. He can do the exercises, and gradually this strength and healing process that we initiate will take over, and he hopefully will be better. That would be, I think, a reasonable plan.
I take a different view. This man's had everything. He's had 3 years of chronic groin pain. He's 25 years old. He's had everything. He's had 3 platelet-rich plasma injections. He's got nowhere. He's had the best physiotherapy. He's got adductor longus tendinopathy, clear cut. He's got a split in the conjoint tendon. It's only a matter of time before he has a complete breakdown into a groin disruption injury. And so for me, he's a surgical candidate. And what I would do with him, even though he doesn't have a sports hernia, I would plicate that posterior inguinal canal wall to make sure that he doesn't get a sports hernia in the future, and I would repair that split in the conjoint tendon and release the adductor. He's had enough time to get better on conservative treatment.
Well, we just heard that we don't know what kind of physiotherapy was given. We don't know exact how this was done and if it was done in the way that we are working with it now. So I would be a bit hesitant with a knife.
Well, I agree with Dr. Garvey, but I think it's time to propose to him an adductor's release. But usually in this case with just adductor-related pain, I don't do systematically a repair of the inguinal area because there is no sportsman hernia, and maybe someone will, some sportsman hernia will arrive, but we have got plenty of time. He's 25 years old, so I will propose him bilateral adductor stenotomy.
Dr. Rabul?
Always, yes, always bilateral, because it's an imbalance problem. And if you do just one side, a few months after, he has pain on the other side. So once, 2 years ago, Ramon Kogat from Barcelona came and he has a huge experience in adductor stenotomy, and he always did bilateral anatomy. So if it's good in Barcelona, I think I can do that.
In some series, it does get up to 90% bilateral, so I'm not surprised to hear that. But he had no symptoms, so I would be watching the non-affected side in this player.
Okay. Me, I've been watching the abdominal inguinal area, you know. And I don't.
Dr. Rabul?
I agree with Mr. Pica. Okay. I agree with Mr. Pica, but I don't know if the both. Maybe only the left. And for the only the left. Okay.
Only on one side.
Yeah.
So he's proposing double.
Yeah.
But you just one. Is that right?
Sorry. For me, on the basis of my experience in sports medicine, that's a fantastic case to show us as the first case that is really justified this project of Aspetar that we would like to go on with Dr. Per Holmisch on the head. First of all, working in the club. Once I was a technician and I was a doctor. You imagine 3 years you have a players and you don't know what's happening with him. You imagine how many doctors can survive as a club doctors with this guy under the pressure of the management of the team. Second things, finally, what imaging he had? Nothing. What kind of physical therapy and prevention program he had? Maybe, maybe no. And finally we came to the surgery. One say he's going to do repair of sports hernia, like if I imagine if he came in Munich, tomorrow he's going to be operated. Other school proposed him tenotomy, bilateral. And you see that really justification of this program that we should establish, and excellent case.
It's almost as if this would be set up for some sort of randomised trial, perhaps comparing surgery and conservative management for this. Okay, look, really, in the interest of time, and I don't want to fall behind because it's going to ruin the rest of our day, if we could just very briefly talk about our second case, the 40-year-old Ironman triathlete who had a history of ongoing calf injury for 10 years but is presenting this time with distal abdominal pain. If we could just perhaps jump straight to the salient examination findings and decide on a plan of action for this fellow. If perhaps I could ask, since Sarko and Dr. Rabul.
I'll make a plan.
Yeah, Dr. Gard.
Physiotherapy. 3-month injury, physiotherapy, always.
And physiotherapy's aim is to...
For what?
Because he's got adductor pain, he's got conjoint tendon pain, and his injury is too fresh to have an operation. This is when I would support physiotherapy.
And I have the feeling with physiotherapy as I have with surgery, it's very different. It depends on who is the surgeon, who is the physiotherapist, what program, what operation. So physiotherapy isn't just something that is one thing, it's a lot of things, just like surgery is a lot of different things. So I think we have to be very, very clear and define what kind of physiotherapy, and I wouldn't even call it physiotherapy, I would call it exercise therapy, done by physiotherapists, like you can say surgery is done by surgeons.
I use the term a groin pain specialist physiotherapist.
Well, for me, I agree with everyone. For sure, I would have him here for 4 weeks to have proper physiotherapy. And then I think that is approximate time that you would have probably a lot of improvement on the iliopsoas muscle. And you will see if the adductor longus tendon and the bone tendon junction is improving in pain, and if there's any point in continuing. And by that time, you'll maybe have a resolution of the conjoint tendon problems, because they were not so, like Dr. Garvey examined him, he was not painful, but there were some tears on the ultrasound. So, and there was some pain on the stretch. So maybe just myofascial reaction, maybe this pain will resolve also. And then after 4 weeks, if there is no improvement, and it's still 9 out of 10, but I doubt that the pain is 9 out of 10, because I don't know, my friend Ibrahim maybe doesn't, you know, when you have 9 out of 10, it's like you cannot find any comfortable position. It's 10 is like a renal colic pain that you think you're dying. So I would be hesitant to say it's 9 out of 10. But anyway, you would have some improvement, and you will see if the pain reduces in intensity, and there is worthwhile to continue a little more with physiotherapy and to try to save the tendon. Or at the end, if there is no improvement and you are under pressure from the club and from the club doctor, physiotherapist, and also where you're working, you need to find a solution, or otherwise the patient will change the doctor, go to someone else and have a tenotomy.
Okay. One last comment on the second patient.
Yeah, I'll just make a comment for the benefit of the audience. The scrotal invagination test that we saw on that patient was popularised by Gilmore, the English surgeon, and it is not typically used for that particular condition. What it is used for is to distinguish between an inguinal hernia and a femoral hernia, a classical inguinal and a classical femoral. What you do is you put your finger inside the scrotum, you control an indirect inguinal hernia, and you look for a bulge from the femoral triangle region. It's not really to be used to detect a sports hernia, because it will always be painful.
Okay, if we could now jump to the final patient, and I really am going to be brief here because morning tea awaits. We have a 17-year-old fellow who in January relates a history of a pulled muscle, which he described as, I'm going to say, in the psoas region. He took 2 days of rest and then had to rejoin his team as they went to Dubai to play a tournament. The pain increased again and got worse over the subsequent 2 months. He's had 7 weeks of physiotherapy, which has principally been exercise-based, and he feels that this is relieving his pain, although it hasn't abolished it entirely. On examination, he was tended to palpate his pubic symphysis, his rectus abdominis slightly. His external inguinal ring had a slight amount of pain to palpate. There was no pain on a cough or a valsalva. Palpating his psoas muscle proximally, reported a 6 out of 10 pain. Adductor longus he thought was 4 out of 10 pain. His pain in the morning was when he thought it was a little bit worse. Zarko noted on examination what he described as an increase in tone in his left adductor longus, which was painless. Resisted adduction was painless, as was flexion adduction and internal rotation. A quadrant position, flexion adduction, internal rotation on the left side gave him slight hip pain. Resisted flexion was painless, but Zarko again noted that while that was strong, it was associated with a lot of accessory movement. Palpating is the strongest clinical finding was palpation of the psoas was painful, and then the addition of a resisted straight leg raise gave him a marked amount of pain. I think at the end of that we were all relatively comfortable that this was primarily a psoas, let's call it a psoas entity for want of being brief. Squeeze, there was some pain on release, so potentially if we're saying there was no adductor longus involvement there, we might have to call the squeeze a false positive. Palpation proximally was uncomfortable. Hang on, Per's shaking his head. Left worse than right, so I might get you to comment on that first.
That was just the squeeze test being a false positive, and the patient was pointing exactly to the adductor longus insertion, and when we palpated the adductor longus insertion, there was a clear difference between the two sides. The ultrasound will sometimes show this, and I think if we might have given Dr. Reed a bit more time and possibility, he might even have seen some differences. But I agree on what you showed us here. There was no big difference on the two sides. But we don't know whether the ultrasound imaging or the MR imaging is actually correlated to the clinical findings and the patient symptoms. No one has ever looked into that scientifically, so we don't actually know. We're just assuming, and we have a good experience from it, but we also know that we sometimes have situations like this, where you have some clinical findings, but you can't support that by the imaging, and the other way around.
Given the constraints for time, is there any argument against the notion, given the current clinical evolution, of continuing on with conservative management for this fellow? Is there any argument for further investigation or intervention other than what's being done for this fellow?
We don't like operating on 17-year-olds. He's a physiotherapy candidate for my money.
Okay.
I agree. He has got good progress during the last weeks, and feels that all three entities are actually progressing. So I would say keep up the good work, and I see a solution out there. Yeah.
Right. I'd like to thank our panel, but especially our patients who volunteered the time on the weekend. And please, our patients who are in the audience know that this has been rushed, but we invite you to come up and talk to us now to kind of get a more full explanation of what's been done and what we planned. To get back on time, it's currently, let's say, 17 minutes past 11. At 35 minutes past, so 25 to, we'll reconvene. That's 5 minutes late, and we'll steal 5 minutes from lunch to make sure at the end of lunch we're back on time and we finish on time today. Thanks again, everybody.